Hello, so hopefully everyone's back from the coffee and networking event, and I'm very pleased now to chair the second session this morning, and I have the great pleasure to introduce my friend and colleague from St. Bartholomew's Hospital, Professor Peter Schmidt. He's a professor of medical oncology, he's an international leader in immuno-oncology, and he specialises in breast cancer, as well as being the director for the Barts Centre for Experimental Medicine. If you'd all put your hands together for his talk this morning on the management of common toxicities in immuno-oncology.
Thank you, John. That's very kind. Talking about side effects is usually a very boring topic. So I do apologize. But I think in terms of immune therapy, in terms of what you need to know in your daily practice, it's becoming really important. The way I always describe it to patients is when we deal with chemotherapy, pretty much everyone gets side effects, but it's about a handful of side effects you need to know about, and we can manage them very well. We've learned this over the last 50 years. When we talk about immune therapy, it's a small percentage of patients who get significant side effects, but they're hugely variable, and it can essentially affect any part of the body. So what we as oncologists are learning how to deal with this, but you as the doctors who see them in the front line have to know about some of these side effects as well, partly about the management, but from my perspective, more importantly about the recognizing that this is an immune-related side effect and knowing what to do. Now, as you all are aware, when we interfere with the immune system, it's a tricky balance, and you have on the right side the immune tolerance, which we obviously try to break through and push the whole system to the left side, where we have an immune response against the cancer, and that's what essentially immune therapy does. And when we look at this, sometimes we get this wrong, and sometimes we push it a bit too far, and that's what we talk about, or what we mean when we talk about immune-related side effects. It can affect any part of the body. The most common side effects we see affect the skin, it affects the bowels, the GI system, liver toxicity, lung toxicity, and some endocrine side effects, which for us as oncologists were slightly new when we first started doing immune therapy 10 years ago. Now we're getting quite experienced with this. The general events, fever, infusion reaction, or tiredness are relatively rare and don't seem to be a big problem in clinical practice. Now, if there's one thing you should remember from this talk, is there's a very simple way of dealing with side effects of immune therapy, and that's using steroids. Steroids are basically the antidote of everything we do. They push the immune system back to immune tolerance, and whenever there's a concern that a side effect may be immune-related, do not hesitate to get in touch with us. Do not hesitate to put patients on steroids, because there are very few situations where you can make the situation worse with steroids. And there are many situations where you make the situation much better and very quickly if you start patients on steroids. Now, this is a recent overview that just shows you which parts of the body can be affected by immune-related side effects. But I would put it the other way around. I haven't come across a part of the body that cannot be affected by immune side effects. So if you find something, if you see patients describe symptoms that are slightly odd, they are not what you would normally expect from cancer patients. And do keep in mind, if patients are on immune therapy, it could be an immune-related event, and talk to us, and we work with you on the right strategy to diagnose and then to treat this. When can immune-related side effects occur? We initially thought there's a bit of a timely pattern, but more recently we realized that these side effects can occur essentially at any point in time. Rash sometimes occurs relatively early on, but we have patients who have been fine for a year and a half and suddenly develop rash. So the fact that a patient develops a rash a year and a half after she started immune therapy doesn't mean it's not immune-related. Those side effects can kick off at any point in time. Sometimes it's triggered by a little viral infection and the immune system goes crazy, and that's why patients suddenly develop side effects. Diarrhea, endocrine side effects, liver toxicity, pneumonitis, all these side effects can, in theory, happen at any point in time. Some of them don't seem to happen very early on, but again, now that we're using more and more combinations, a lot of this is changing as well. Important things are most immune-related side effects are reversible and respond quickly and well to steroids, and only in very few situations we have to use other immune suppressive drugs. For me, and I think everyone who works in immune therapy would hopefully agree with this, early recognition is important and early treatment is important. If you treat a patient early and in the right way with steroids, the side effects go away and patients can continue with the treatment. Whereas if you wait too long, then it sometimes takes a lot of time to get those patients and get those side effects settled again. We need to work, and that's what we try to demonstrate to you with the lung MDT, we need to work as a wider team. And although the oncologist is in the center of managing side effects, we do need to work with specialists, and some of them you saw here this morning, specialists who are lung, liver, heart, or whatever specialists, and have experience with immune therapy. Because again, I think it's important to optimize patients' care in this system. If you look at a simplified table how to deal with immune side effects, that's basically all of it in a nutshell. But I will go through some case reports with you just to illustrate how we deal with this in clinical practice. Now, if you talk about grade 1 events are usually very mild events. We try to treat them symptomatically, and patients usually don't require systemic steroids, and we can continue with the immune therapy. When it comes to grade 2 events, for most events, we would carry on with the immune therapy. Only for a few events, we need to be a bit more careful. And again, if it comes to diarrhea, to liver toxicity, to pneumonitis, these are areas where we sometimes hold the treatment, even if they are only grade 2 events. And just to, well, what is a grade 2 event? For example, diarrhea, 4 to 6 times above the normal frequencies, that is already a grade 2 event, and we need to think carefully whether we need to put a patient on hold if she develops that side effect. We would, again, in selected adverse events, already give steroids here and give systemic steroids and then wean over a period that shouldn't be too short. There's a temptation to start patients on steroids and then stop within a few days. But again, what we've learned with some of the side effects, when they're more substantial, we need to stay on with steroids for several weeks. When it comes to grade 3 events, that it should be systemic steroids, and we often say, let's start on IV steroids first and then switch to oral steroids. And the recommendations are usually to taper slowly over up to 4 weeks if patients had severe side effects from immune therapy. It is the dose of steroids is usually a good starting dose, tends to be 1 milligram per kg body weight. Sometimes when the reactions are a bit stronger, we need to go higher, but you're never really wrong with one milligram as a dose. And sometimes we have to repeat this to get on top of the side effects. So that's basically the management of immune-related adverse events in a nutshell. What I want to do is just share a few cases from our practice with you, just to get you a bit sensitized how things are in clinical practice. So the first case is of a 54-year-old lady with advanced melanoma, and she was on nivolumab monotherapy, so single-agent immune checkpoint inhibitor. 2 weeks after she started therapy, so relatively early on, she called the office and said, I have a rash on the upper arms and thighs. So if you look at the classification, upper arms and thighs, that accounts for a grade 2 rash because it's less than 30% of the body surface area. So what would you do? If this patient calls you, what would you do with this patient? Would you just give them a lotion? Would you initiate topical steroids, supportive therapy, hold the immune therapy, which is obviously the oncologist's decision, or completely discontinue checkpoint inhibitor therapy? Now, with a relatively, this is a mild to moderate reaction, we would consider topical steroids, we would give patients antihistamines, we would continue with the therapy, and in this patient, the rash resolved relatively quickly. Often these rashes resolve within 24 or 48 hours, and patients can continue with their treatment then. Just want to show you a few photos, a few pictures of patients with rash to show you there isn't a predominant type of rash. It can basically, any rash you can imagine, we can see with immune therapy, whether it's just red hands, whether it's blotchy macular papular rashes. whether it gets more severe. And here on the right side, you saw a patient who didn't receive treatment when he should have received it. And as you can see, those rashes can exacerbate if we carry on with immune therapy and if we don't deal with this in the right way. And again, in very rare cases, we see very dramatic rashes if patients aren't managed properly. This is not what you see in your routine practice, and this is not what you see in your routine practice if the patients are managed well. If patients develop rash, we start them on steroids, this improves quickly. But it is important because patients often don't tell us that there is a rash, because if it's not in the face, it's not obvious. So it's important to know if there's a rash, let's treat patients very early on, otherwise it can exacerbate to this level. Second case is a 57-year-old patient with triple-negative breast cancer and who had then metastatic recurrence with lung metastasis. And she was in one of our phase 2 trial, which now actually has turned into phase 3 trial and has just demonstrated that patients who get chemotherapy and immune therapy live substantially longer with triple-negative disease. And this patient had a fantastic partial response, as we see in many patients. But several months later, she suddenly presented with dry cough and shortness of breath. Now, in terms of what would you do? What is the differential diagnosis for this patient? If she calls you, what do you think of? We did a CT scan, and I don't know whether Neil is still here. He could tell us exactly what we see on the CT scan. But even after the CT scan, there's a differential diagnosis. Is it disease progression? Is it lymphangitis we see of the cancer? Is it infection, or is it pneumonitis? And what we often do in this early phase, if it's not 100% clear, we cover both sides for infection and for pneumonitis. And we started this patient relatively quickly on steroids, first with 1 and then escalated to 2 milligrams per kilogram body weight, and held the treatment with immune therapy. Now she improved relatively quickly. But she still, even several weeks later, we still see some residual pneumonitis. But the important thing is this patient continues to respond to the treatment. She's now off the immune therapy, and 8 months later, she's still in a very good partial response, and the side effects are fully under control. Here you can see her scan, how quickly it did improve. The third patient is again a breast cancer patient, triple-negative breast cancer, and we run a large program of triple-negative breast cancer studies. And she had her immune therapy as a neoadjuvant, as a preoperative therapy, chemotherapy together with immune therapy, and then just came up to us. It's a tough chemotherapy she was on, and said, I'm feeling more tired, and was some degree of general malaise. And again, the question to you is what you make of that. Is this just what you expect in a young patient who was perfectly well and then has weekly chemotherapy, tough regimen with paclitaxel, with carboplatin, followed by AC? Or do you need to think about other things in this situation? And this is how vague it sometimes can be. It's not obvious always that this may be an immune-related event. So should we just reassure the patients? Do we need to admit the patients? Do you do further investigations? We decided to do further investigations and looked at hemoglobin, slightly lowish, 9.7, but probably not enough to explain those symptoms. But the TSH was elevated at 26, the rest was relatively normal. So our working hypothesis was it's not, yes, there is some anemia, but it's probably not just general chemotherapy-related fatigue, but she is developing hypothyroid function. And how would you manage patients in this situation if you have a patient who's becoming slightly hypothyroid whilst on immune therapy? Would we just start her on thyroxine? Would you start her on thyroxine plus steroids? Would you start her on thyroxine and stop the immune therapy? Yeah. So we would just give her thyroxine, because actually once you have your inflammation of the thyroid gland, you can't stop this anymore with steroids. And the immune therapy is not going to make that worse. It's like an autoimmune thyroiditis, and it has already gone to a point where it's in a hypothyroid function. So stopping the immune therapy doesn't help in this situation as long as the patient is stable. And giving steroids doesn't help either. But we, of course, need to replace the patient with thyroxine and can manage that very well. Similar case, similar treatment. In fact, it was the same clinical trial. We saw a lot of thyroid changes in this child. 51-year-old lady, again, reports with very similar symptoms, but has some palpitations. Now, I would assume you agree that we don't just reassure, we don't omit it, but we investigate this further. Now, in this patient, we had a TSH of 0.2, and we had a T4 of 26 or 28. I can't read this anymore. But clearly, again, the thyroid function is altered. What do you do with this patient? Their working hypothesis is she has a hyperthyroid function. This is immune-related. There's no other reason why she would have this at this point. Would you admit the patient? Would you start her on cambimazole? Do we get help from a friend? Endocrinologist is always good, but if you have done this a few times, then you may actually decide to initially monitor her yourself. Watch and wait, close monitoring of thyroid levels. What would you do? So it comes down to how well is the patient. And if she has palpitations, you may phone Dr. Lyon and give her a beta blocker. But actually, we decided in this patient, often we do this unless they're critically unwell with their hyperthyroid function, to watch and wait. So why would we do that? Because one of the things we have learned is when patients become hyperthyroid, it's an initial inflammation, and very soon that will burn out and patients will become hypothyroid. So by the time the carbimazole has kicked in, patients are already hypothyroid, and you play catch up. And that's exactly what you see in this patient. You see the spike in the levels, and you see them coming down, and at that point we start a thyroxine, and the patient's absolutely fine. It is something when you haven't got experience with this, you want to be proactive and say, oh, patient's hyperthyroid, I need to do something. But most patients with this mild hyperthyroid function are fine. They may need a beta blocker, otherwise they're fine. And we watch and we see over the weeks, it is always, I've never seen a single patient where the thyroid function doesn't come down, where a hyperthyroid patient doesn't turn hypothyroid over the next few weeks. The next case, again a case from our breast practice, a 54-year-old lady who was well. She has a history of celiac disease. She had a fantastic response to the chemotherapy and to immune therapy. So all her cancer was completely gone at the time of surgery. And she came off that trial in around May or June time. And in August, we get a call from another hospital. So 2 months since she came, or 3 months since she came off immune therapy. And so they mentioned, so by the way, your patient is with us and she has diarrhea 10 to 15 times a day. And what do you think that is? Well, it's obviously, I'm talking about immune-related side effects, but the hospital there assumed it was her celiac disease. And we said, why would her celiac disease suddenly get out of control if she hasn't eaten the wrong things? And we said, please do start her on steroids, because we think it's an immune-related event, which can happen in a delayed way. 2 months, 3 months after immune therapy, not impossible. Something kind of triggered it. The immune system is still active. And so this patient was started on steroids. A sort of intermediate level dose with 30 milligrams, which is about 0.5 per kg, slightly below what we would want to do. The hospital, unfortunately, didn't tell us that her LFTs were also elevated at about 5 times upper limit of normal. And they gave her the steroids for a short period of time and then stopped. Didn't tell the patient. We tried to say to the patient, please come to us. She lived far away, didn't come to us. Now you can imagine where this heads to. 4 weeks later, the patient comes to our clinic, seriously unwell, grade 4 liver function tests in the thousands, and has diarrhea 15 to 20 times a day. And again, now the picture is very clear. This is not celiac disease. This is a late effect of immune therapy. It's immune-related hepatitis and immune-related colitis. What you do with the patient? Well, the options for you are you can try to manage this by observation. Urgent admission, IV steroids with 10 milligrams, IV steroids with 1 to 2 milligrams per kg, oral steroids. What would you do? There are different combinations. Do you want to keep her as an outpatient? Admission. Yeah. Do you want to try it with oral steroids? No. So it's very clear this patient needs urgent care. IV steroids, 10 milligrams are also not enough. She needed high-dose steroids. We admitted her, she did improve, but it did take quite some time for this to resolve. The diarrhea went away very quickly, but the LFTs remained elevated. And it has been very tricky to manage that. We got our hepatologists involved, we did a liver biopsy, we did all the infectious causes. Ultimately, it was an immune-related hepatitis. And although she improved, her liver function tests remained elevated initially at 15 to 20 times upper limit of normal, and it came then down to about 6 to 8 times. And this is one of the patients where we escalated immune suppression, but where we over time then started de-escalating, and she is well now, but we still see some degree of elevated liver function tests. And it raises the question, had this patient been managed optimally back in August, whether she would have been in a much better situation at the end of September, because she was started too late on steroids, not at the right dose, and not giving the steroids long enough. The last case I want to share with you is one of our breast cancer patients. You probably get which disease I treat very commonly. And this is a patient who was on single-agent immune therapy, metastatic disease. As you can see, there's the pre-sternal disease. She responded well to her single-agent immune therapy, and then presents after 3 cycles, after 9 weeks, with some fatigue, bit of shortness of breath, bit of diarrhea 4 times a day, and fever. All of them mild, all of them slightly vague, all of them things where you can say, do you react to this or do you ignore this? We did in further investigations, the LFTs were slightly elevated, platelets were a bit low. Otherwise, the respiratory function was pretty normal. We saw some discrete changes in the lung on the CT, which you probably can't see. We also saw a bit of edema in the ascending colon. What would you do with this patient? What do you do if you have this? Nothing is really tangible. It's all there are a few little events. Well, we decided to do the obvious and put the patient on steroids. Yeah, you put immune therapy on hold, put the patients on steroids, and as you can see, the platelets go up relatively quickly, the liver function tests go back down. We sometimes have diffuse immune activation, which can address different symptoms. It can lead to thrombocytopenia, to pyrexia without a different cause, to LFTs, to diarrhea. And you just need to be aware of this. These are mild symptoms, but often have one common denominator, and that is ultimately immune therapy in these patients. So I hope I haven't frightened you of immune therapy. It is ultimately, these are more or less our worst cases of the last 5 or 10 years. Immune therapy is very well tolerated, but we all need to know what we do. And often patients present with relatively subtle symptoms, where the key task for you and for us is to work together and recognize them. And because they are autoimmune type reactions, and the earlier we recognize them, the earlier we treat them, the better it is for patients. This is not always the task of the specialist, so we don't always have to get the chest physician or the endocrinologist involved. I think as oncologists, we have responsibility in recognizing this. As GPs, you need to be alert, you need to be switched on that these could possibly be immune-related side effects, and get in touch with us, and then we can discuss together what is the right strategy to diagnose this and to treat it. Steroids are the most effective therapy. We hardly ever, I can remember less than 5 cases in the last 5 years where we had to use stronger immune suppressants, but we work in breast mainly with PD-L1 drugs. When you give CTLA-4 targeted drugs, you sometimes need stronger immune suppressants. Rule out other causes. Of course, work with other subspecialties, especially for some of the procedures. The last point really is if we do need steroids, it is worthwhile giving them over more than a week. And if there was a significant side effect, it often takes a bit longer for those side effects to improve, and sometimes we need multiple courses. But so going back to where I started, compared to chemotherapy, we see significantly less toxicity with immune therapy. But the closer we look, the more we see. It's less than in chemotherapy. It's very simple. You have your hair loss, you have nausea, you have your risk of infection. We know about this very well. with immune therapy, it's much more diffuse. It's a whole range of symptoms, and any symptom a patient may tell you about could possibly be immune related. So please do not hesitate. Get in touch with us if some of our patients, our shared patients, come with symptoms, and we then can work out together whether or not this is immune related or not. Thank you very much.
Is there any questions?
Thank you very much for the great talk. One of the barriers for the use of the steroids in timely fashion is the fact that some of the colleagues whose expertise are not cancer treatment, they think that steroids can undo what the cancer treatment of immunotherapy does. Do we have any evidence, or I would love to hear some message?
It's a really important question, and we were concerned about this 5 or 10 years ago when we started doing immune therapy. Now we know once the immune system is going, it doesn't matter whether you put steroids in there or not. The tumor effect, the anti-tumor effect doesn't stop. And we have plenty of evidence from patients on trials who were on steroids and who continue to respond. For example, of these cases of patients who were on steroids for many months without immune therapy still have an excellent response. The most important thing is patient safety. And we should first worry about patient safety and secondly about response. But if a patient truly responds to immune therapy, they will continue to respond whether or not you give them steroids.
Great, thank you very much.
I think there's the next question. Let me come back to you.
I think the gentleman answered my question, actually.
Ah, brilliant.
But I just would like to add to that. I have several patients who are on immunotherapy, and there's certain guidelines that we use in different trusts that they don't, if they're on a tapering dose of steroids, that we don't usually start them on immunotherapy because there's some information that makes the immunotherapy less effective. But as you were just saying to me just now, that you're saying there's some studies which show that it's still effective.
So thanks for asking this. So what I would say is, it doesn't undo the work immune therapy did in terms of cancer control. So if you have a patient, let's say with breast cancer, had a fantastic response to immune therapy, and you have to give her steroids, it doesn't mean she's suddenly starting to progress. On the other hand, yes, in most trials and in most recommendations, we would hold the immune therapy until the side effect has settled and until the patients are fine without steroids. So thanks for asking that. So I didn't mean you should carry on with the immune therapy if you have significant side effects. You do need to hold until they don't need steroids anymore. Yes, please.
Yeah, hi. Thank you for the talk. Are these side effects dose-driven, and is there any contraindication to immunotherapy?
So immune therapy, we generally give it a flat dose. So most drugs were initially dosed per body weight, but these days we are giving a flat dose for most of the drugs. And therefore they're not related to the dose. And we never do dose reduction with immune therapy. So it's different to chemotherapy where you have there's a clear correlation between the dose and the side effect. With immune therapy, it isn't. The dose can be little or high, you can still get the side effect. So for that reason, it's not dose related. The second part of the question, contraindication. There are very few, but so one contraindication at the moment is still having significant autoimmune disorders, because these patients were excluded from other trials, and in those patients we just don't know. Let's say if you have severe colitis, autoimmune colitis, then if you give immune therapy, that can flare up. We just haven't got the experience there, and I would be very careful. In sort of milder autoimmune problems, we are gradually getting experience that we can treat some of them, but if it's substantial autoimmune problem, then not. In terms of lung, if patients have signs of pneumonitis or other diseases that may affect the lung function, again, if you think about would a patient tolerate pneumonitis, that's something we need to keep in mind. Some of the infectious causes of, for example, patients having active hepatitis or HIV is still one of the exclusion criteria for most of the trial, and I would say we haven't got enough experience for that for patients with active hepatitis or HIV, although some of the Some of the HCC trials included patients with hepatitis, and it's possibly okay. But again, what we're worried about is if you already have an infection, you boost the immune system, that the reaction gets a bit too strong. So and I think the last point, and Tom made this earlier, is patients also should be well enough to have cancer treatment. And there's a temptation for all of us to say, if the patient's unwell and performance score of 3, we can still give immune therapy because it's so well tolerated. The challenge is you need to still have an immune system that's active, and patients need to have enough time to activate immune therapy. So if you feel a patient is probably passing away in the next 6 weeks and has already performance score 3, but I don't think immune therapy is generally justified, because the immune therapy needs time to kick in, and the patients need to be well enough. So a lot of these contraindications are not black and white, and it again comes down to having an experienced team advising the patient on what the best things are. But in my opinion, these are the main things they look for.
Is there any mortality from immunotherapy, and what's the commonest cause?
So patients can die of immune therapy, yes. And each of those side effects could, in theory, be fatal. So pneumonitis, if it's not well managed, not recognized, can be a fatal complication. Colitis could be, hepatitis could be. Now these causes are very, very rare, but and if you manage patients well, then it's very unlikely to happen. But we know of fatal cases, unfortunately, yes. Yes, please. The microphone is coming your way.
When the patient is started in the first line of treatment, and if they're not getting proper response, I mean, you do follow up and then check the response. But when the stage comes that it's not responding to whatever the desirable response from there, then switching from first line to second line to third line, how do you decide, and how do you do the patient go to further testing for that?
So I think it comes down to each of the cancer types, and what I would normally say, and that's a very general statement, don't switch a cancer unless the cancer, don't switch treatment unless the cancer is growing. So if you say patients didn't respond well, that should mean the cancer is growing. If the cancer is stable, then I would carry on with the treatment. Only if the cancer starts growing, we should switch to a different treatment. Because what we sometimes see, for example, with immune therapy is that the tumor is stable, but it's stable for 1.5 years. And if you then have already switched to chemotherapy, you take away some of those benefits. So it's looking at, do we need, is the cancer out of control with the current treatment? And if so, then we switch to the next treatment.
I mean, optimal response. I'm not responding, but what was expected, like after 2 or 3 years of treatment? If his response is not that optimal as expected,
so
then
the optimal response in patients with advanced cancer is that the minimum we want to see is that the cancer does not grow. And there's no benefit from being more aggressive then and saying, if the cancer is stable, pushing it further back, I wouldn't recommend. And that's not something we would do in breast, but it's very similar in most other diseases. As long as the cancer is stable, then we would not switch the treatment. There may be some rare situations where you have to do that because the patients get symptomatically worse. But otherwise, if we treat patients with advanced cancers, what we try to achieve is control the cancer for as long as possible. And sometimes that can be years with immune therapy, even if the cancer doesn't shrink.
Thank you.
There it was, yes. I pass it on.
Sorry, this question is not about the side effects of immunotherapy, but how do you maintain an optimal immune system from very young age, from baby, infant to adult age, and like factors like stress affects it, alcohol affects it, and what other things that may interfere in the immune functioning of the body during the course of life?
That's the holy grail of medicine, isn't it, almost, the question. And you're asking a completely wrong person. I'm a simple-minded oncologist who comes in when it's all going wrong. But what I would always say is do things in moderation. That's sort of my personal motto in life, which I often get wrong. But it comes to having moderate levels of exercise, having a healthy, not crazy diet in whatever way you do, is being sort of low on drugs, whether it's smoking or alcohol or other things. I think these things do play a role. Stress is an important point. I don't think we have the answer to that, but we know that stress can affect parts of the immune system. Whether they are the factors that are relevant from a cancer point of view is unclear at the moment. But I think if we advise our patients to have a sort of a lifestyle in moderation, then I don't think we can go completely wrong.
But any inflammation is making person prone to cancer, I guess, anyway. Like
So
ulcerative colitis.
inflammation doesn't tend to be a good thing, no.
No.
And so if you can avoid inflammation, that is usually a good thing, yes. Yes, please. John, you will need to stop me, don't you?
So we're just running a little bit behind time now. So I'm sure there'll be an opportunity around lunch to ask Peter any further questions you may have. But we'd all like to thank you for a very interesting and enlightening talk.
Thank you.
So next on the agenda this afternoon, I'm very pleased to introduce my colleague, Dr. Tobias Arknor, who's the Executive Medical Director of the Sarah Cannon Institute. And he's going to share with us where he sees the future of cancer treatment to be in 2030. Toby.
Thank you. Thank you. I changed the title, actually. I was meant to talk about new changes and the future of immunotherapy, but this effectively includes, and what I think is really important, includes you as a group of GPs and interested collaborators, because we need to work together. So in the next 10 to 15 years, we need to see much more engagement of the GP community. We need to much more, as you can see already, managing side effects, but also we talked about earlier today about circulating DNA, preventative therapies, screening, and so on. So my talk has changed a bit, and I will also talk about immunotherapies, what we're doing, exciting stuff in our research unit. But so bear with me. Of course, you understand here, if you look back 10, 15, 20 years back, where we simply understood genetics, basic genetics, the Human Genome Project revealed that some oncogenes are driver for cancer. This wasn't a long time ago. We take this all for granted these days. And then, of course, over time, that these oncogenes had also a role to play in cancer. Then probably the last 10 years, we tried to target oncogenes or tumor suppressor genes in a way to stop drugs with very much targeted drugs. And again, 5 years ago, we would have had a symposium of targeted drugs and personalized medicine. So these immunotherapy, immunotherapy for everyone has really driven the focus away from where we are. And of course, I'm looking forward here is how do we make sense of all of this? Targeted therapies, immunotherapies, outcome. I talked this morning about clinical outcome and the way how we integrate this with electronic medical records. How do we analyze our databases? I will talk a bit about artificial intelligence and so on. So sorry, I've changed that slide a bit in my talk a bit. Early detection, disease monitoring. I think that's something where this ball is in your corner effectively. We need to work together how we do early detection, how we identify patients early who at risk to develop cancer. We had already in our debate, and some of the questions were about lung cancer screening. We do very commonly in the GP practice fecal occult blood testing. Again, as you have seen, the tests have changed. These days we're doing DNA tests. And again, there are different roles. It's particularly, and Professor Foster highlighted this early, it's not anymore about the pathology report, you are a lung cancer and we treat you as a lung cancer. It's about systems biology. How's the tumor look like under the microscope? What are the genes? What is the microenvironment? What's the PD-L1 status? Just a few to name. It's actually much more complex. The key thing for you and as an oncology community to understand, the differences between genotype, the what can be inherited in some cases. 15 to 20% of patients have inherited cancers, as you know. What is the phenotype? What does it look like? Squamous cell lung cancer versus an adenocarcinoma. How do we treat them? What are the outcomes? So this will be the future in terms of basic understanding of cancer. It's much more than just the histology report. So early cancer detection, I think I just mentioned the fecal occult blood test era are over. You do DNA test, of course, and I'm talking here about 2030, so don't be offended if you don't do it at this point. Increasingly, one of the questions was earlier the early detection through circulating DNA. Then urine, saliva. I will give you some examples again where you as a GB practice have the machine at your practice to say, hey, there's something flagging up, and this potential patient needs to be reviewed, and more diagnostics need to be made. Liquid biopsies, again, where we currently sit in the oncology treatment arena is, and I gave you some examples when and where and how I use circulating DNA, is patients who have cancer, where we can't biopsy. But again, you will see it will shift into your surgery, where you will do circulating DNA liquid biopsies. Key thing, the challenge we have is that there are millions of tests, not millions, but around 300 tests available. Some of them are approved, some of them are not approved. And often, again, and you will see this in your GP practice, is that people say, hey, do the test for your patients to get a risk score for cancer, get a predictive gene test. Patients can actually, by the way, buy these tests from Amazon and often come to you into the practice and say, hey, what should I do with this? And that's where the trouble starts and where we all get nervous because, as we know and have seen in so many cases, that patients may have genes popping up on these tests and they may quite be relevant in terms of germline alterations, variants of unknown frequencies. We, within HCA in the group, have strong discussions. Should this be the DNA testing at this point be performed in the GP practice, yes or no? I think right now we hold this back. If gene testing is done, this usually through a clinical geneticist as well, supportive, that these tools, these are new tools, they're off the shelf, you can buy, are used in the right way. Again, urine test, these are the latest tests. It's a test which uses extracellular vesicles, which again can be bought, and urine test can predict whether you're at high risk of breast cancer or colorectal cancer. Interesting things, they will be approved at one point. And the latest what I've seen, again, one of my patients, friends who's running this company, they have developed a cancer breathalyzer. And it's kind of super interesting. So effectively, this breathalyzer can detect chemical compounds in your breath and could look for biomarkers. I mean, we could use, through our research uses for biomarker monitoring, we can measure hazardous substances, but also we could potentially monitor disease. So this is, remind yourself, 2030. So we're not there yet, but these prototypes are out there and we're doing research on this. And in 10 years' time, this machine will be in your practice and you will have a quick breathe into this machine and we can monitor disease and treatment. I think the most exciting thing, and I'll give you two examples, is the use of artificial intelligence. Effectively, when we're talking about artificial intelligence, it is often so diluted, this word. We're talking about two things, natural language processing and machine deep learning. So two different ways. Natural language processing effectively is, and I'll give you an example, which HCA in the US has done. So we have done this in one of our core markets in Kansas, where patients, think about the US, get admitted to a hospital, to A&E department. They usually get a CT scan upfront, regardless what your symptoms are. We don't need to debate whether it's a good practice or bad practice, but they get CT scans and they get reported in an A&E department without necessarily specialist review. So in our Kansas market, we had about 10,000 patients who went through A&E out of these 10,000 scans, a computer program, a natural language processing program, picked up unstructured words, so irregular structure. So things like, which are not normal, and the radiologist just reported it, couldn't, however, find anything, didn't trigger second review. This system did. So they found about 500 patients which were second reviewed by a specialist radiologist, in particular a chest physician, chest radiologist. And out of these 10,000 patients who just went for any course into an A&E department, we found 50 patients with early stage lung cancer, which could be operated on. So think about the systems we have to use, which work in the background of our practices, which effectively pick out the outliers, pick out the, effectively the natural language processing system is, meant to pick out. So really interesting here. Machine deep learning is a bit different. So in pathology particularly, here's an example on breast cancer, not early detection, lymph node, sentinel lymph node biopsies, where pathologists have reviewed and have worked against a machine. A computer effectively reviewed the lymph node, and through training programs and training algorithm, the machine was effectively better, had a higher sensitivity in detecting early, so positivity in the sentinel lymph node. So again, where we can use these systems, very sensible, and to detect cancers early. So again, this is changing. This is as we talk. Research studies out there. We recently went to China and have visited a hospital. I was pretty much amazed. So usually when you see a hospital, you go to the ward and say hello to the ward sister, go into a patient room and see the patients, how they're treated. Actually, the tour started in a pathology department where about 20 liquid nitrogen tanks were full of tumor samples. In 2 years, about 20,000 samples tested. Next to the pathology department was the IT department where exactly that happened. Integration of pathology, IT systems, and by the way, the data were connected to the social security number, again, the outcome data. So how long do patients live and what is the outcome? So a very smart way, I think, and we need to reconsider and think how we can integrate all this. So the way we build hospitals, structure hospitals, is we have to rethink the old way with these technologies coming in. I'm talking to you about new immunotherapies. I think I don't want to overburden you with this. It's pretty much targeting the cycle of immunity. And again, there are various different steps. But effectively, what we have talked this morning about are two different drugs, PD-1, CTLA-4 inhibitors. They're kind of what we call, and what you read in the day-to-day newspapers, are checkpoint inhibitors, and they do great stuff for various different cancers, sometimes not. So right now, the challenge for us is to identifying those patients who respond, and you heard some markers like PD-1, PD-L1 expression, tumor mutational burden that is relevant. How can we get better? It's probably through manipulating the immune system even more. So letting T cells, as you heard, we activate T cells and we stop the interaction between PD-1 and PD-L1 receptor. How can we do this? For example, to get better blood supply into the tumors. We could, for example, give chemotherapy or radiotherapy to have more antigen release. Again, T cells have a better chance to identify these neoantigens and target those. There are, and again, this is really important, about 40 top targets, and there's a list of 200, but this is the top 40 chart of drugs which are currently developed. And there could be checkpoint inhibitors, vaccines, and viruses and other antibodies in development. The challenge we have is, in this very nice article just recently published, we in the clinical trial setting can do so many trials. And you just see here CTLA-4, one of the checkpoint inhibitors. There are about 250 trials where you have a combination of chemo plus CTLA-4, immunotherapy plus CTLA-4, and radiotherapy plus CTLA-4. There's so many opportunities that with all these targets and all these drugs, we will never answer these questions. So we need to be very smart and very focused in identifying the right biology, the right way. And it's not, again, having, learned and being trained in the old chemo days where you just add chemo plus something new. These days are over. We need to have good preclinical evidence. We need to have good preclinical models to effectively show that these drugs are available. So I don't want to go into details what's the next super combination. Actually, this year we had several super combinations. Nivolumab plus IDO inhibitors, for example, failed. $800 million in one trial, just blown away because drug development just added one drug to the other, and let's try and see how it is. And obviously there's a big competition. You've seen Tom's graph of the thousands of different combinations. I think that's the wrong way how we do drug development. And again, in our clinical research unit at Sarah Cannon, we are very mindful about this, that we're trying to pick the right horse. We not always get it right, but at least we try. And again, what I'm showing you as well, that you need to have the right infrastructure to do this as well. I think personally I'm interested in, and I'm moving now away from these checkpoint inhibitors you read every day. I'm now talking about cellular therapies. Again, the latest, we had a few patients reported in BBC and newspapers around ASCO, our annual cancer conference, and the great response to TIL therapy. So when I'm talking about TIL therapy, effectively it is tumor-infiltrating lymphocytes. I think Tom this morning showed it in one of the initial slides. So lots of T cells around the tumor and the microenvironment. Those are the cells which are usually recognizing cancer neoantigens, cancer protein, and those are the ones who are fighting cancer. So we know if your tumor is rich in TIL, you respond better. So effectively what we're doing here is extracting by taking tumor chunks, extracting the TILs, enriching the TILs, and then reinfuse these TILs like an autograft into patients. It sounds also simple, and it's actually a massive, complex way. It's effectively like an autograft in hematological cancers. These T cells have to be extracted, fragmented, and then also enriched. And we're currently doing this at UCLH in our hematology unit because patients are treated like a transplant effectively. They get, before they get reinfused, conditioned with cyclophosphamide, fludarabine, and then get for a week IL-2, again a cytokine which can make the patients extremely sick. But we've done it, and it's actually very exciting to see some of the results. And I want to share some of those. They were yesterday presented in Washington, D.C., so you get the latest data here on how TIL therapy for us at HCA, Sarah Cannon, is a new way of offering this to our patients. So here, this is a phase 2 study in patients with melanoma, so skin cancer, patients who failed standard of care immunotherapy like nivolumab, CTLA-4 inhibitor, BRAF inhibitor. So all the good drugs where we see patients long-term survival, these patients failed those drugs. I'm reporting a few data, the 60 patients in this cohort 2. Again, you don't need to bother too much about, it's about 50 patients, heavily pretreated, around 3.5 lines of prior therapies. And what you can see here, that everything facing south, on the right side is response. So we have a patient with complete response. All the patients up to 30 are, or more than 30% reduction are partial response, so 40% partial response, and some patients stable, and only a few patients who progress. Remember, these patients were heavily pretreated. They were treated with immune therapy. We're using now their own immune cells, enriched, reinfused, and we achieve this. And we know from some data we have seen from the NIH and Bethesda in the US, where early work was done, that some of these patients who respond, they are long-term survivors. So effectively, are they cured? We don't know, but certainly they're long-term survivors. And again, through this clinical trial, formally we could confirm that 40% have good response. There's another 30% of patients who have stable disease. And again, response in stable disease sometimes doesn't really, in immunotherapy terms, doesn't mean there's a big difference. So patients who have stable disease can also be long-term survivors. Again, here you see at this trial the duration of therapies, the kind of bottom, the arrow showing ahead there, they're still responding. And again, we're just showing an update, or have shown yesterday these updates at the meeting. Here you can see the response and duration. And of course, the imaging as well, it's always nice to see here the pre-treatment, big paravertebral mass. 18 weeks later, the immune system, patient's own TILs are fighting the cancer and causing this response. Of course, you will have heard about CAR T-cell therapies. Again, in solid tumors, we are not yet as far as the hematologists are. So in hematology, they actually, this year, 2 approved drugs. Actually, the NHS has approved the first CAR cell therapy for children with ALL and large cell lymphoma. Again, in hematology, it's pretty easy because the T-cell, the genetically modified T-cell receptors are targeting the CD20, which is a B-cell lineage effectively, which is only happening on B cells, and most hematological cancers are B-cell disease effectively. In solid tumors, we have a bit of a challenge that the risk of, if you only manipulate one receptor, you have lots of cross contamination through healthy tissue effectively, and there's a high risk that you get severe toxicities. So the kind of next generations, generations 3 and 4, we call them tandem or ICARs. They're in development, so again, not far away to go into our clinical trials. But for solid tumors, you still need to wait. Probably next year, in 2 years' time, we can update you on this. So there were great questions about what can we do, what can the GP do to support patients. We increasingly have seen that the gut microbiome, so what we eat and how we keep healthy our gut, has an increasing role. We know that the intestinal microbiota can affect not only maintain inflammation, but also can support gene instability, cause mutation. If you look on the right side as well, can be pro-immunogenic in terms of cytokine release. So again, the question about being inflamed, as in the body in general, having inflammation, is often controlled through the GI system, through the gut. And what do we know so far? So really 2 recent high-profile studies have shown amazing, I think very amazing things. Here, the first bit, a study in melanoma, patients who were treated with nivolumab, the PD-1 inhibitor. The study looked into how did the gut microbiome look in patients who were responding, opposed to patients who were not responding. And there was a clear difference in the signature. The patients who responded had usually a much broader diversity of microbiome versus the patients who did not respond had a very limited, very selected type of microbiome. So, think this further through, and we're starting to run a study. Can we actively, USGPs, proactively manipulate the gut microbiome? Right now, I can't say this, and I would be cautious, but certainly that's where the research goes. So it's not only drug research we're doing, we're researching, we're working towards a holistic approach, the microbiome and the microenvironment as well. The other thing, interestingly as well, the second study as well, is they have also looked into melanoma patients who received immunotherapies and could find that patients who, while they were on immunotherapies receiving antibiotics, those patients who received antibiotics did worse. What are we doing as cancer doctors on a day-to-day basis with chemotherapy? We constantly prescribe antibiotics. You have a bit of a runny nose. USGPs do this all the time. Antibiotics. So effectively, if we're prescribing $100,000 drugs and we can wipe out this effect by antibiotics, this would be wow. I mean, this is just, again, these are early data, but I just want to highlight this. This will come into your terrain, and we need to think about healthy living, diverse microbiome, but also cautious use of antibiotics. Empowering patients, you will see all your patients come up with a little, hey, this is what I found on the internet. Again, you will be challenged on a regular basis. So link yourself into Google and Smart Patients Inspire. They're interesting, if you look into this, blogs, working groups, they're pretty professional. It's not anymore like 10 years ago, they were kind of like patient groups and they kind of recommended things. These groups are kind of interesting. There's lots of important stuff to read, and I only can recommend this. And again, we're talking about 2030, so there's lots of time to go. And but USGP, you're the first contact in this part, and you need to know what patients doing. Futurology of disease, I think, again, what we, and I tried this morning in the way I introduced HCA and our cancer service is we want to integrate, we have to integrate research, we have to integrate primary service, secondary service, interconnected through systems, through IT systems, in a completely different way, the way we have done it. And that's a big challenge, and you will probably ask who's paying for this, but again, if we want to continue for world-class medicine, we have to think and restructure this. Of course, as a clinical trialist, this is super important, clinical trials. And it's not only drug trials, it's research in microbiome, circulating DNA, and so on. So I had a little story here about the patients I saw, how's my patients in 2030 looking like. I will spare you of this. I think in 2030 at this point, we're closer to a cure. Early detection, immunotherapy, understanding biology, these are the buzzwords. Collaborations between GPs, oncologists, and patients as well is the most important thing. Thank you very much. And I think really important to introduce you to Mo. I think for me the highlight today, because we will actually hear from Mo his story being a patient with GI cancer, being a patient, I think, who underwent a journey as a family way, a patient who has Lynch syndrome, developed colorectal cancer, and went through the system of family is known to have Lynch syndrome, who's following up this patient, what are the colonoscopy frequencies, and so on as part of Lynch syndrome, patient being treated with chemotherapy, patient who participated in clinical trials, and finally had the experience on immunotherapies. Mo, I want you to talk. I talked enough, so it would be great. So please give Mo a warm applause.
I've got a mic. I'm connected to a mic. So I planned to talk, so do I carry on?
No,
go ahead.
Yeah, do your talk.
Okay. So I want to first of all say how much respect, appreciation, and gratitude I have for you all here today, for dedicating your lives, your time, your energy, your resources in choosing the profession that you're in today to ultimately help people like me who find ourselves in a health crisis. And so I want to be of value and help you help others who might be in a similar situation to me. And to do that, I've broken the story into 3 parts. And the first part is how I got to the diagnosis, those signs, those symptoms, those clues that I can now clearly see that were pointing to the cancer, which I missed. I got diagnosed 11th of December 2014, and that's almost a month away from my 4-year cancerversary. Since that day, I've been taking one day at a time, and it's quite difficult to remember what life was like pre-cancer, but I know I was working as student development director at Kingston University. I know I would spend a lot of time in the gym or on the running track. Running was my escape. I have 5 nephews, and at the time their ages were 1 and 16. and I desperately tried to get them all to support Tottenham Hotspur Football Club, failing miserably. And I'd spend a lot of my weekends in personal development events trying to improve all areas of my life. But in 2014, life was a huge struggle. I'd be in meetings and I'd get a stomachache and I'd have to get up, walk around, go to the toilet to relieve myself. When it comes to my running, it didn't make sense. My 5K runs were taking 5 minutes longer. My 10K runs, 10 minutes longer, even though I was putting in more effort. And without even noticing, I dropped 5 kilograms. Jeans, I'd never need a belt for, all of a sudden I would. I didn't know what was wrong. And it was watching Tottenham play one evening when I felt a pain just continue to develop over the course of the evening. And I went to bed that night thinking the pain will be gone in the morning. It was October. The morning came and I woke up and the pain was so severe that I walked to A&E that day. The nurse asked whether I'd taken any painkillers, and I didn't. And her words I still remember. We feel pain, we take painkillers, and the pain goes away. And I felt stupid because was I wasting the nurse's time? Was I wasting the doctor's time? The NHS time? And I was given some paracetamol. And I'd rather have been at work. For the next 5 hours, I was emailing, texting, and even making those phone calls, even though the sign says, do not use a mobile phone. But the doctor that day said the blood showed that I was anemic and that it was unusual for a guy my age. I was 31 at the time. And he said we need to put some cameras inside to find out what was going on. So over the next 6 weeks, I had more tests, blood tests, ECGs, X-rays, ultrasound. And then the paracetamol moved up from codeine to cocodamol to tramadol. The pain was there every minute of every day, keeping me awake at night. And I was told to use the tramadol sparingly. And so I was using it to help get some sleep. Fast forward to December, I have the cameras inside, the endoscopy and then the colonoscopy. And the consultant or doctor that day said the inflammation was too large. We couldn't finish the scope. You're going to have an emergency CT scan. Together with the scan results and the biopsy, we'll know whether you have Crohn's or cancer. And so for the next 5 days, I was agonizingly hoping for the best in Crohn's, yet fearing the worst in cancer. And then it was confirmed to be cancer. Now, at the consultation with the surgeon that day, lots of thoughts came through my mind. And one of those was my previous 10 years of personal development was somehow preparing me for the biggest challenge of my life, not yet knowing the severity of my cancer. And so a week later, they had an MDT meeting, and I met my oncologist for the first time. It wasn't Toby, somebody else. And I had 2 questions, stage and grade. Because by that time, I'd been on Google and did a bit of research. And so when I was told it was stage 4 and that I had a small chance of success, I was broken, I was shattered. I somehow squiggled my initials on the consent form, questioning what was the point of even having any treatment. The tumor was too big, it was inoperable, and chemotherapy was prescribed to begin on Christmas Eve. That was 4 days after I had just turned 32. So it was happy birthday, happy Christmas, happy New Year, with not much to be happy about. I wasn't sure if I would see another birthday. And this leads on to the second part of the story, the treatment. My life had just changed overnight from waking up, getting ready, and a 90-minute commute to work. It was now primarily home and hospital, and very isolating. I now needed help with my day-to-day life, my chores, my shopping, and cleaning up after my mess, because chemotherapy is brutal. The sickness, the diarrhea, the fatigue, the weight loss, the loss of appetite, the loss of taste, the mouth ulcers. One of those is bad enough. And when you combine them all together, it's just unimaginable. And so I worked with an integrative physician for other areas of my life. So we focused on my mindset, my emotions, my psychology. And I did meditation, I did gentle yoga, and I examined my entire life. Socrates once said, "The unexamined life is not worth living." And with death staring me in the face, I wanted my life worth living. And I began asking deeper questions. What was the meaning of it all? I remember reading a book once called Man's Search for Meaning by Viktor Frankl, documenting his survival of the concentration camps. And it was now Mo's search for meaning. And I explored my childhood, the fears that I had, but also my goals and my dreams. And I reconnected to some of those, how I wanted to write books and share my truth and transform the world. But the vision seemed very remote because of the dire medical situation. I needed blood transfusions to get me through chemo. And after the first 6 cycles, I was ready for the first CT scan. I had the scan, I got home and was about to crash on the sofa, and I got a phone call from the hospital. They detected a blood clot in my lungs. I think you call it a pulmonary embolism. And I had to go straight to A&E. I then spent a week in the hospital until it was safe enough for me to come home. My bloods were showing safe levels. But the CT scan also showed my tumours to have shrunk, readying me for surgery. And the thought of having surgery was petrifying. They said they'll take out my colon, possibly my stomach, my spleen, my abdominal wall. And the stoma nurses marked an X, the perfect spot for the ileostomy. And once more, I was squiggling my initials on the consent form, questioning what would be left of me. But surgery went well, as I could have hoped. They took out my colon as planned, a wedge off my stomach, so I had a sizable piece left, and left my spleen and abdominal wall in place. And referring to the cancer, the surgeon said he was confident he had taken it all out. I then spent 2 weeks or so in the hospital recovering, relearning how to walk again with the help of the physios, and adjusting to a life with my stoma. And I've had a number of challenges with the stoma, leaks, skin irritation, as well as prolapses. But after surgery, I had another 6 cycles of mop-up chemo and began going back to work again on a phased return, 2 days a week, which was regaining some kind of normality. But the scan showed there to be bad news once more. The cancer progressed straight into the lymph nodes while I was on chemo. And so things were now up in the air as again I sign a consent form for second-line chemo. I then hear the words disease management, which at best is a life on chemo, which isn't something I wanted. And in a bittersweet way, I got my wish. December 2015, a year on from my diagnosis, by which time I had 18 cycles of chemo, a major operation, blood clot in my lungs, and I was to be given 3 doses worth of bad news. The chemo's not working, the cancer's growing, and there's nothing else we can do for you. And this leads us on to part 3 of the story, which is the immunotherapy. So I'd just been kind of told my cancer's terminal, yet I was probably one of the calmest people in the hospital as I asked, what can we do? And it opened up a fascinating conversation about immunotherapy. I was told I was a good candidate for it, but the problem was it's not on the NHS. And when I asked how much it would be to access it privately, I was told I needed to be a millionaire. But my oncologist said he was going to refer me for an individual funding request to the NHS, but warned it might take 3 to 4 months of hearing back. And so in the meantime, I was passed on to the Sarah Cannon Research Institute, where I got to meet Toby. So 2016 began with hope. And that hope was because of a condition called Lynch syndrome. Now, Lynch syndrome is a genetic condition. Someone who has Lynch is at 80% risk of developing bowel cancer. And for women, the additional gynecological risks. The NICE guidelines in the UK are for all bowel cancers to be tested for Lynch syndrome. But we know that's not happening. I didn't know I had Lynch confirmed until 8 months after my diagnosis. I was referred straight away to the geneticist, but I wasn't seen for 5 months, and the bloods came back 3 months later. Now, if someone knows they have Lynch, you can screen them, colonoscopies and other kinds of scopes. And there's also a cap-free aspirin study that shows people with Lynch syndrome on aspirin reduce the risk of developing bowel cancer. It also identifies families at risk. So my brother and sister, 50-50 chance of having Lynch syndrome. Their children, if they have it, have that same risk. So the guidelines are there to prevent further cancers, but we know it's not happening. Bowel Cancer UK did a Freedom of Information request and presented their report this year, where out of the 154 hospitals in the UK responding to this, only 34%, that's 52 hospitals, I believe, were doing Lynch syndrome tests for all bowel cancers. And when it comes to best practice, it's only 17%, which is doing the Lynch syndrome test prior to treatment. And so I share that because not everybody knows about it. And the reasons we hear: lack of knowledge, lack of staff, lack of money. Yet the test costs £250. Cost of treating bowel cancer, $25,000 on regular conventional treatment. But it's this Lynch syndrome that offered me hope, because the study I saw in 2016 was Lynch syndrome patients with MSI respond 70 to 80% on pembrolizumab, which is why my medical team were desperately wanting me to get this drug. But the trial I wanted was postponed indefinitely, and then I was put on a phase 1 study while we waited. But 2 months into that, my nodes progressed, one being visible on my neck. So I was taken off the phase 1 study. The NHS come back and say no, they're not going to fund the treatment. So no trial, no NHS funding. We appealed to the drug companies. Can you provide it on compassion? And they too said no. It's available on the market. If you can pay for it, you can get it. Now my MP, Keir Starmer, he was new, 1 year into his role. I hadn't known who he was at the time. Represented me to the Department of Health. And someone in Jeremy Hunt's office didn't want to know either. They batted it back and said it's one for NHS. So the system said no, but humanity said yes. My friend said, let's fundraise. But I wasn't in a place to do so, to come out and kind of plead and beg for my life. Am I worthy? Am I deserving? And what is the price on life? Some of the questions I had to ask. And when I inquired about the cost, at one point I was told it will cost $20,000 a month. And then we got a price of around $10,000 per cycle. And working through the demons, I put my ego and pride to a side and I said, yes, let's fundraise. And the response was phenomenal. From my family, friends, my community, to complete strangers all over the world joined in. We launched a crowdfunding campaign to raise £200,000, and that just spread amazingly. My MP press released his communication with the Department of Health, and the press picked up on it. And Toby very kindly gave up a lot of his time to meet with reporters, and we both made it on ITV London News one evening, and the Evening Standard and various other publications. In total, we raised £190,000, allowing the treatment to begin. Now, the baseline scan, which I had the day before treatment, reported unequivocal progression with signs of spread into the spleen and the liver. And that was the trajectory without any treatment. I ended up having 16 cycles of pembrolizumab over the course of a year. It was 2 mg per kilogram every 3 weeks. I had a scan after every 4 cycles. And then the first scan came back with some incredible results. One of the nodes showed a 70% reduction. Some of the other nodes, 40%, 30%. Subsequent scans continued to show small reductions in size until a year later it was suggested to pause the treatment, which we did. I had my last scan in October last month, which is 16 months on from pausing the treatment. And it came back with stable disease, no new sites. And I think one of the nodes has shown small reductions still, which is incredible, and I'm very grateful. Now, the side effects that I've experienced on immunotherapy are very different to the ones on chemo. For a year and a half, I had allergy symptoms all year round, even in the winter. I have hay fever, so getting it in winter didn't make sense. I had a blocked nose where I couldn't smell anything during that time. Vitiligo has appeared all over my legs. This was while I was on the immunotherapy. And once I stopped the treatment, arthritis has kicked in. So my hands, my shoulders, knees, toes, I thought I was going to sing a song, head, shoulders, knees, and toes. But all my joints have arthritis. And then I started developing some scary symptoms. So I had a subtotal colectomy, so I've still got a chunk of my rectum there, which it's not been active since surgery. And then all of a sudden, I'm passing stuff out. Initially mucus, and then fluid, and then blood. And that scared me. Had a chat with Toby, and we had a flexisigmoidoscopy. And that came back with an ulcerative colitis diagnosis. And so those are the arthritis, colitis, and vitiligo, I'm told, fall in the autoimmune spectrum, which is consistent with what we've seen today. And so I started earlier by saying I take one day at a time, and that's still the case now. Whether it's arthritis or colitis, if it's neither of those, it's my mental health, where sometimes I find myself just breaking down, unexplainably trying to make sense of the last 4 years where it's been shock after shock after shock. And I'm working with a psychologist at the moment to process some of those. But when I'm not, with the extra life that I've been given, I try to make the most of it. So I've published a book this year. I'll just show you. It's called Choosing to Stay, How Cancer Gave Me My Life Back. And I share the choices that I made and the lessons that I learned in it. And some people reading it have come back to me and said, after reading your book, I've chosen to have chemotherapy. Because the pressure is so high for a cancer patient. You have people saying, you need to go on an alkaline diet. You need to go on some retreat in somewhere in the world. And the pressure is so high. And so the book is for anyone there who's going through a real challenge, maybe one of your patients, I don't know. But I'm really grateful to be here today. And it was amazing to see Toby's slide earlier where he said empowering patients. Now, I navigate my health challenges the best as I can with the help of my medical team, which continually changes with new faces being brought in as the challenge changes. But one other thing that's been consistent is me being empowered to have conversations with my doctors and specialists around what we do going forward and being involved in the decision making, which I know isn't the case for too many people out there. And I believe it's something we need to embrace. The system, or, you know, I've been thrust into the world of cancer or the business of cancer without wanting to. But the system kind of would have, you know, the drug companies, the NHS, Department of Health, would have allowed me to die, even though a drug is out there that offers real hope. And so I'm grateful to be here today. And my question to you all will be, how do we encourage a system that empowers more patients to have conversations? When I started the cancer story 4 years ago, when I walked into A&E, a lot of the times I felt like a statistic or a patient number. You know, I'm asked, what's your patient number, before I'm asked, what's your name? And something's not right there. And here I am today where I feel like I'm a person. So I thank you all for your time.